Hello and welcome. My name is Suzanne and I'm a Trainee Assistant Practitioner with the Let's Talk team. And today I'm going to be talking you through the Let's Talk service at the hospice as part of St Anne's 50 and 50 events. Here you can see the makeup of the team, which includes 2 counsellors and 2 Trainee Assistant Practitioners, or TAPs for short. We work as a team to provide psychological and bereavement support and counselling to patients and families at the hospice. Our TAPs provide Step 2 interventions, while our counsellors provide Steps 3 and Step 2 interventions where appropriate. We'll break down exactly what that means a little later on. At the moment, the TAPs are in training, but we hope upon qualification they'll be assistant practitioners, so we can continue to provide support using this model. So as I've just mentioned, the Let's Talk team is here to provide psychological support and counselling to family members and patients visiting the hospice. We work within the multidisciplinary patient and family support team, which provides a wide range of resources and expertise that allows us to help and support clients in a holistic way. It's quite often the case that psychological distress can be caused by practical issues in life that can be helped with the support of social workers, for example, who can help with social support for clients should it be needed. While this multidisciplinary support is available to all clients, it's important to always take into account the client's consent when seeking additional support. In accordance with our therapy agreement, we only break confidentiality if the client is at risk to themselves or others, or if they disclose any information relating to serious criminal activity. It's also worth noting that our counsellors are both members of the BACP and abide by their ethical framework for counselling professionals, as well as local hospice safeguarding policies. We offer support in line with the NICE Guidelines 2012, which sets out the basic structure of our support model, as well as making sure we are always evaluating whether our service is appropriate for the hospice environment. Referrals for support often come from within the hospice and can be done by any member of staff who feels it would be appropriate for one of their patients. We have a single point of access for Let's Talk, so when somebody is referred, they are assessed by one of the team and assigned to the appropriate person. We offer support in line with the 3-step system set out by NICE 2012. We tailor our services around these steps, and the hospice as a whole is encouraged to keep these steps in mind in order to continually support the mental well-being of everyone who comes through the hospice. The role of every member of staff at the hospice refers to Step 1 intervention, which is undertaken by all staff. This will involve recognising and referring appropriate patients and family members who may require additional support to the Let's Talk service. This can also take the form of offering reassurance or comfort to those who are in psychological distress and using basic listening and empathy skills to allow patients and family members to feel understood and listened to in times of psychological discomfort. Steps 2 and Steps 3 are offered by the Let's Talk team in 3 different ways. Grievance support. This is for people who have lost a loved one recently, or could be a number of years ago since that person has died. This will include mainly Step 2 interventions that we would class as expected grief, that does not have complex factors surrounding it, such as trauma. Psychological support. This encompasses both Steps 2 and Steps 3 and looks to help people who may be struggling with a lifelong illness or symptoms such as pain or loss of mobility. This can vary greatly between people, and so the support may be listening or empathizing, or looking at breathing activities and practical steps to manage symptoms. People accessing psychological support may be particularly vulnerable if life has changed suddenly due to illness. This is where the multidisciplinary team and signposting to other agencies and resources can be particularly helpful. The final service is counselling, which is an exclusively Step 3 intervention. These are only carried out by the counsellors using a person-centred model of therapy. We work with clients at this step who may be suffering with complex grief due to the circumstances of the death being traumatic or unexpected. Often the work will deal with difficult emotions surrounding the death within complex family dynamics, where family support may not be readily available to the client. We try to work towards an 8-session time limit with people who may have developed more entrenched depression or anxiety over the time following a bereavement. We also work with those patients who come into the hospice to die or to manage very complex challenges with their illness, often looking at the existential questions of life and death, and how to have these discussions that may feel inappropriate to have with family and friends. As mentioned previously, our service is open to anyone who has a connection with the hospice. This connection often starts through the medical referral of a patient into hospice care. At this point, the patient themselves can be referred to Let's Talk, as well as any other appropriate services. Family is also screened to see if support would also be suitable for them. This is all done internally through our own systems. We do have instances as well where we have a reciprocal agreement with other hospices. Sometimes it's the case that friends and family can live in other parts of the country, and so if somebody dies in a different hospice, but the family live in our area, then we are able to take them on as clients under our own Let's Talk service. This is something that we can arrange also for people who may live far away from St Anne's and are wishing to access support closer to home. It's important to note that whoever comes to us at the hospice, that they receive the same high quality service and that they are not excluded or treated any differently due to their gender, religion, age, disability, ethnicity, sexuality, or trans or cis status. One of the biggest challenges we have had as a service over the past year has been moving from a primarily face-to-face model of support to working almost exclusively by phone or by video. This has brought challenges to not only the clients, but also us as providers of support, as this has been a new way of doing things for us all. We have had to be mindful of data protection, particularly as we learn to work in this new way, as there have been new risks when discussing confidential topics over the internet. We've been using a system called Accurix for video calls, as this is recommended and used by the NHS, and guarantees information is treated in the correct ways. This system for video calling does not store any client information and is only accessible to those who are sent the specific session link. The benefits of this system is naturally that we're able to continue to offer some form of face-to-face work with clients, despite the fact that we are geographically separate. This has also had the unexpected benefit of helping to provide support to clients who may not have been able to access face-to-face support at the hospice due to their illness or mobility issues. We have been encouraging clients to use the Accurix software for this reason, as we have also noticed a decrease in missed appointments and for some better clinical outcomes when being able to talk through video. We've also been offering telephone appointments to people who may not have had the technological skill set required to use Accurix, as well as people who may wish to use the phone for their sessions. The benefit of this has again been our ability to offer this to a wide range of clients and to continue our provision of services throughout the pandemic restrictions. Phone sessions have been effective and have had good outcomes for the clients, as well as allowing our staff to work from smaller spaces or even from home, meaning that we can often talk to more clients in a shorter space of time. Some of the issues with both of these ways of working can be the inability to control the client environment. We have had issues where clients have wished to have sessions whilst driving or while other people are present, and have had to consistently reinforce the importance of safety and confidentiality. We've also had some issues of hesitancy of using new technology, as many of our clients are older and may not be used to talking over video software. Some clients may find face-to-face appointments over video to be very uncomfortable, meaning that phone is the only option for the time being. It has also been the case that some clients are still waiting to access the service, as they are keen to wait for face-to-face in-person services only. Overall, we feel we've adapted to the challenges of working in this new way really well and are hopeful to continue to incorporate these new ways of working into the service longer after we have returned to face-to-face sessions. Many clients, particularly those with jobs, have responded very well to this remote way of working, and it has allowed the team to be more flexible in how we deliver psychological support. It's important to examine not only who we support, but how we work with our clients. What underpins all of the support we offer at the Let's Talk services is working with person-centered principles. This means putting the client's needs first and working in a way that is useful to them, regardless of who they are or what issues they may be struggling with. Our counsellors and TAPs come from a person-centred background, which is important for fostering the culture of support we wish to provide. At step 3, our counsellors use person-centred therapy to help clients feel encouraged to bring their own issues to the service. The client will be offered an environment of non-judgment in order to explore these issues and become more self-aware, allowing them to effect whatever change they feel is necessary for their own personal growth. The counselling is led by the client and not directed by the counsellor. Many clients with no prior knowledge of counselling believe that the counsellor will resolve their problems for them. It's often a helpful experience to feel a sense of ownership and control over the way the client feels, allowing them to accept themselves as they are, reducing the feelings of shame and supporting the autonomy of clients. We often work with trauma at the hospice, which can pose additional challenges for clients. The traumatic experiences and memories can be very fearful to approach and talk about, meaning the feeling of safety within sessions is paramount to the client's ability to open up and share. We may use techniques or resources available to us to aid clients in talking about these topics, such as creative therapy or CBT techniques, depending on what is most helpful to the client. One of the most important parts of trauma work is developing a trusting relationship so that the client feels safe and able to look at the trauma without being left with the repercussions of doing so alone. At step 2, we also employ person-centered theory of being non-judgmental and using active listening. But we also look at well-being interventions such as sleep hygiene, goal setting, or gratitude practices. Although counsellors can provide step 2 interventions, this is often delivered by trainee assistant practitioners in the context of bereavement psychological support. Again, this is based off the client's lead and will match both what the client issues may be, as well as what fits best for how the client wishes to be supported. At all steps, we keep in mind that it may be appropriate or helpful to signpost clients to other services or resources. These may be online resources or local groups that the person may wish to attend to in order to support themselves better once counselling ends. When looking to the future of the service, we are always considering new ways to develop both the skills and techniques employed by the team to ensure that all our clients receive the best possible care. In the near future, our counsellors hope to establish online support groups aimed at tackling anxiety and bereavement issues within a group context. This expansion will provide an additional route of accessing hospice support, which will open up our service for clients who may not want to visit the hospice, even when restrictions have been lifted. Although COVID-19 restrictions have prevented our service from conducting the majority of face-to-face appointments, we have found new ways to provide the same high-quality care. Using accurate software has allowed us to continue to offer face-to-face appointments, albeit through a computer screen. Despite the challenges associated with introducing new ways of practicing, as a team, we continue to find new, innovative ways to continue to support our clients. We believe that we will rise to any future challenges and look forward to implementing new ways of working into our standard practice. Thank you for listening.